My name is Ruth Namazzi. I'll just put on my video for a while. I'm a lecturer at Malaria University, but I'm also a pediatrician at Mulago Hospital. I take care of children with sickle cell disease at Mulago National Referral Hospital. I also I subspecialize in hematology and oncology. And I am really passionate about this topic of sickle cell disease. And I hope that by the end of this talk, we would have learned how to care for children or persons with sickle cell disease, but also formed important collaborations for us to advocate and push this forward. So I'll take off my video so that I can save on some bandwidth and then start the talk. There's time at the end for us to discuss the way forward. So that is the outline of the talk. This is a very big topic, but I've tried to compress as much as possible. I think we will have to perhaps, have other talks if your secretariat will allow. So the background, I think everyone knows that sickle cell disease is the most common inherited blood disorder, and it's caused by an abnormal hemoglobin, which is called hemoglobin S. We all know that the normal hemoglobin is hemoglobin A, but hemoglobin S is an abnormal hemoglobin that comes about as a point mutation in the beta globin gene. And this results from the substitution of valine for glutamic acid at position 6. This is not really, important, but I mean, some people might want to know. Everything, all the pathology comes from just that point mutation. There are different types of sickle cell disease, but sickle cell anemia, which is a homozygous type, is the most common and the most severe form. And in Uganda, almost 99% of the sickle cell disease is sickle cell anemia. And so when you talk about sickle cell disease in Uganda, you're almost exclusively talking about sickle cell anemia. It's estimated that over 300,000 children are born globally with sickle cell disease. However, the important thing is that 80% are among us. So sickle cell disease is a sub-Saharan disease. It's our problem, it's our challenge, and we need to own it. In Uganda alone, it is estimated that 20,000 children are born with sickle cell disease, and it's estimated about 80% die before their 5th birthday. This data has changed a bit. I think we're down to 50%, but that is still a lot. So from this data, we think we have about 125 to 150 people with sickle cell disease in this country. So what is the pathology? What happens? What is special about the sickle hemoglobin? So under areas of low oxygen tension, this sickle hemoglobin, instead of being discrete like this on the left, as you can see, it polymerizes. It forms long polymers like this. And this change the shape of the red blood cell, which should be discoid like this, to this shape. And this is where the pathology begins from. This sickled red cell is rigid. It does not move very easily through the blood vessel, so it clogs the blood vessel and causes ischemia and pain. But it also adheres to the blood vessels and causes a lot of problems like endothelial damage. And the red cell also, because it's rigid, it easily dies. So there's chronic hemolysis, which causes chronic anemia, as we shall see later, causes vaso-occlusion, but also in more complex mechanisms, works with white blood cells, reticulocytes, and platelets to cause vaso-obstruction, to cause tissue damage. The end game is a chronic hemolytic anemia, a painful crisis that eventually affects every body system in the body and causes progressive organ damage that eventually leads to the early death that we see in sickle cell disease. So therefore, given the multisystemic nature of sickle cell disease and given that it's a progressive disease, if we do not do anything to stop it, then it's going to progress to end organ damage with a very early mortality. Even in the United States, even in Europe, people with sickle cell disease generally die about 20 years earlier than the expected, than the healthy adults, the other healthy adults. So still, sickle cell disease is associated with early mortality. So intervening very early before the organ damage happens is very, very important. So therefore, you need to target or treat sickle cell disease in a comprehensive way, targeting almost all the complications that can happen earlier now. Targeting one complication will not do, because like I've showed you, it's a multisystemic disease. It will affect the brain, it will affect the lungs, it will affect the sexual organs, it will affect the bones, it will affect the lungs, okay? So it's not just a blood disease, it's actually a multisystemic disease. And that is why sickle cell disease has now become one of the leading causes of heart failure, kidney failure, and sexual dysfunction in adults. So therefore, what does comprehensive care mean? It means the prevention, the screening for, and treating of all sickle cell associated complications across the lifespan. So from childhood into adolescence, into early adulthood, into late adulthood. So it's across the lifespan. And studies have shown that comprehensive care for sickle cell disease improves outcomes. Things started to change in the United States and Europe when people with sickle cell disease had comprehensive care, when they had clinics and centers that were targeted and were specialized for the care and treatment of persons with sickle cell disease, when they came up with treatment guidelines that targeted sickle cell disease. So stopping to think of sickle cell disease as, you know, an acute disease where someone comes in with pain and then you give them analgesia and then they go. Thinking of it as a chronic disease, thinking of it as diabetes, thinking of it like the way you think about hypertension, and looking at this person as someone who needs to grow into adulthood and trying to prevent complications. So what does it entail? It begins from birth, early detection of sickle cell disease. So screening at birth. This is something that we're working on with the Ministry of Health, but you can also work on in your forum. You not advocate for screening at birth. That's that each child that is born, we get to know their sickle cell disease status and start early interventions. Then through the first year of life, the first years of life, the first 5 years of life, 5 to 12, 12 to 18, and then 18 onwards. And these are the things we're going to talk about today, as you can see in this diagram. So what does the care of children and adults involve? So it's kind of a three-tier or a four-tier approach that I like to think about. So health maintenance, okay, so what do? You educate, okay, what is sickle cell disease? What does it do? What can we do to prevent it? Then you prevent complications. Infections are very common, so you give penicillin and malaria prophylaxis, immunization, and then you screen for chronic complications. Then at that level, the next level is you treat acute and chronic complications. If it happens that this person comes in an acute complication, what do? You need to manage their pain, acute chest syndrome and fever and other complications that we shall talk about. And treatment of these complications is important that you treat them in a standardized manner, in a guided approach, which is guided by evidence. And then at the third level, you try to modify the disease, okay? So sickle cell disease has two types of treatment. Treatment that will modify the disease but will not cure it. And then at the top, curative treatment. So we have treatments that modify the disease. Hydroxyurea, chronic blood transfusion, L-glutamine, or people call it Endari, or Voxelata. These are things that have been approved for disease modification, and we shall talk about them later. At the highest level, you aim for cure. And the two things that we know cure sickle cell disease are stem cell transplant and of late, gene therapy. Those we shall talk about another day, but you need to know that those things exist and you can actually offer them to your patients when indicated. So what does the first tier involve? Education and counseling. Education and counseling is both for the patients and their caregivers. I'm a pediatrician and I deal with parents of children with sickle cell disease. So what do we counsel them about? Inheritance patterns. Tell them that it is inherited. It is not the fault of the mother or the father. They simply were born with sickle cell disease. And therefore, the next pregnancy, if you're having children in the same man, the chances are that you can actually have a child with sickle cell disease, and empower them with that knowledge so that they can make an informed decision. You are not supposed to tell them to divorce or not to have children. Empower them with that knowledge. Complications of sickle cell disease. Educate them about pain. Educate them about fever. Educate them about splenic sequestration. Educate them about acute chest syndrome, so that they can be empowered to understand when the complications happen. Educate them when to seek for care. You know, for all fevers above 38 degrees centigrade, they should come to the hospital. So wherever possible, encourage your parents, your patients to have a thermometer to monitor their temperature. Some temperatures, they can stay at home. But when the temperature goes above 38.5, they need to come to the hospital. For parents who have children less than 2 years old, teach them to palpate for the spleen. Acute secretion crisis is a killer, but a mother can tell that this child is weak and I can feel that the spleen has enlarged. So please educate them how to palpate the spleen and when to come. Okay, the child is weak and you feel the spleen has enlarged, let them come. There's a whole education package that we have for parents and patients of sickle cell disease that I could not summarize, but these are some of the key aspects. So when you get a patient who is newly diagnosed, please talk about those things. Okay, then we give prophylaxis against infections. Children and adults with sickle cell disease are at a high risk of getting, especially bacterial infections against encapsulated organisms because their spleen loses functionality very, very early in life. About 5 years of life, they really don't have a functional spleen. Therefore, we protect them against infections by giving them penicillin prophylaxis. And what we are using here in Uganda is PenV, 25 milligrams for those less than 3 years, and then 250 for those more than 3 years, twice daily. We discontinue at 5 years, but this is not really evidence-based from studies in Africa. But if a child has had a splenectomy or has had a pneumococcal infection, very severe pneumococcal infection, the guidelines are that actually continue penicillin prophylaxis for life. The practice here depends, varies between hematologists. Some actually continue because we have a very high infection rate, so some continue, some don't. Malaria prophylaxis, I didn't put what we are using because many of you are using different things. I know in Mbale they use chloroquine, in Mulago we use Fansida. In other countries, they use other different drugs like Progranil, and there's a current study that is going on to see if dihydroartemisinin and piperacin is actually superior to Fansida, and this might actually change, but give them malaria chemoprophylaxis because once they get malaria, they're at a very high risk of dying because of severe anemia. Immunization. So the guideline is that children should receive all their immunization according to the local immunization schedule. But in addition, you give 2 additional doses of PCV23 at the age of 2 and then the ages of 5 years old. Okay, so please give them their booster at the age of 2 and the age of 5 years old, especially if you're planning to stop the penicillin prophylaxis. Nutritional supplements. So a lot has been talked about nutritional status of children with sickle cell disease and adults. They're generally micronutrient deficient. They're deficient in zinc. They're deficient in vitamin D, vitamin A, and vitamin E. Okay, and they might actually experience higher metabolic rates than non-sickle disease control. So they might actually need more nutrition and a careful diet. So please give them a balanced diet. Do not restrict foods, but give them a balanced diet, knowing that they actually need higher energy needs. However, the role of routine micronutrient supplementation is not well studied, and the recommendation is weak. The recommendation is that you replace whatever is deficient. So if you find a child is zinc deficient, you give them zinc. If you think they're vitamin D deficient, you give them vitamin D. But routinely giving multivitamins has actually not been recommended. In our local guideline, we give folic acid at 5 milligrams daily because we know children who have hemolytic anemias, of which sickle cell disease is, get folate deficient. We did a study in ginger, really using zinc for prevention of infection because we know zinc has an effect on immune function, and the results are going to be published. But what we found out is that at baseline, 60% were very zinc deficient. And even after giving them zinc, almost 40% remain zinc deficient. So already they are, so we're wondering, why are they zinc deficient? Should we actually routinely be giving them zinc? So study your patient very well and decide if you need to give them a supplement, but make sure that they have a balanced diet because they have a very high baseline metabolic rate. So the other comprehensive care for sickle cell disease means primary stroke prevention. Stroke is a very common complication that we see in sickle cell disease. It is debilitating. It affects the parents, it affects the children, and really changes the lives of these children and adults with sickle cell disease. So the best way is to prevent it. So primary stroke prevention means that you screen for the stroke risk. So children at risk of stroke have what we call abnormal transdoppler ultrasound scan readings. This is really like you've seen on this side. You're looking, you put a probe at the temporal side of the head and measure how fast the blood is moving through the vessels. And it has been found that if the velocities are more than 200 centimeters per second, that child is at risk of getting stroke, almost 300 times someone who is normal. So you need to do something when you find those velocities, and you can only do that if you screen. So the guideline is that all children between the ages of 2 and 16 years should have at least one TCD reading scan every year. So if it is normal, you repeat it after a year. If it is conditional, that is between 170 and 199 centimeters, you repeat it in 6 months. If it is abnormal, you must act. Okay, so the guideline is you put this child on a chronic transfusion program, if possible. So that means you'll be giving this child blood every 3 to 8 weeks to maintain their hemoglobin S level below 30%. Or what is feasible really in Uganda is to start hydroxyurea, as we shall explain later. The feasibility of chronic blood transfusion is difficult in our setting where blood is limited, but also because we know that chronic blood transfusion has its own complications, okay? Screen for renal disease. Renal disease is one of the complications that kills adults very early. It starts early in life from the age of around 2 years, but rapidly increases from the age of 20 onwards and kills adults really, really rapidly. So the guideline is that for comprehensive care for sickle cell disease, start screening children above 10 years for renal disease. Do a dipstick every year for proteinuria. If it is positive, okay, then you go on and do additional tests. You do an early morning albumin creatinine ratio, and if it's abnormal, there's a ratio, I think, of greater 1.5. You refer to a nephrologist who is going to start renoprotective medication like ACE inhibitors and other things. Okay, if it is negative, then you repeat the result every year. This is something that you can easily do in your hospitals, in your clinics. Just do a dipstick and see if there is protein. The dipsticks that we have look at gross proteinuria. So by the time someone has gross proteinuria, the kidney damage has actually already started, and it's time for you to act. Okay, then pulmonary disease. Pulmonary hypertension is also a leading cause of mortality, especially in adults with sickle cell disease. So you need to screen for it early. It also begins early in life, but peaks in adolescence and then in early adulthood. It is not routinely recommended to screen for pulmonary hypertension, okay, for doing echoes in asymptomatic adults or children. But using history and physical examination, you can screen for children who have asthma or COPD or have adenoid hypertrophy. These are the people that you go on if they are, they have symptoms that are suggestive of a pulmonary disease. You go on to do pulmonary function tests, and then you refer to a pulmonologist, okay? So routine pulmonary functional tests in children with sickle cell disease are not recommended. Only do them in children and adults who have symptoms of chronic pulmonary disease like asthma or COPD, okay? Then we are seeing that our children are growing, okay? They are growing, they're becoming adults, they're becoming adolescents, and they're getting into relationships. So we need to counsel them about their reproductive life, okay? So counsel men and women, okay, now they've become men and women or young adolescents with sickle cell disease to have a reproductive plan, okay? Talk to them about it. Do they want to have children? Do they have a partner? What is it? So they have to have a reproductive plan. Offer contraception for those who are sexually active. This is a topic you must have to avoid unintended pregnancy. Pregnancy is a high risk, is very high risk in sickle cell disease. Okay, it's associated with mortality for the mother, but also very poor outcomes for the children. Okay, so tell them that. But if you have a good follow-up plan, actually you can have a healthy baby. Educate for the need of testing partners of persons with sickle cell disease. So if you have a young lady who is in a relationship with a young man and the young lady has sickle cell disease, it's important for them to know the sickle cell status of the young man. Because lo and behold, if the young man is even a carrier, the chances of getting a child with sickle cell disease are very, very high. If the man is AA, then the chances of their children will at the most be carriers. So please counsel them so that they can test their partners. I know that this has a lot of stigma our patients have told us that, once they disclose their sickle cell disease status, their partners leave. But, talk through with them, get that relationship with them, they'll be able to disclose. Stop hydroxyurea. We shall talk about hydroxyurea in people who want to get pregnant, because we don't know the side effects of hydroxyurea on the fetus. So if someone wants to get pregnant, stop it 3 months before, such that you can have a washout from the body, so that it doesn't affect the unborn child. Okay, so that is prevention. We haven't even started getting the complications. So you can see that we do a lot to prevent the complications from happening. But in many, it still happens even when you try to prevent. So you need to have a treatment plan. Treatment of acute and chronic complications, there are so many. We cannot talk about them today. These are among the commonest: pain, crisis, acute chest syndrome, severe acute anemia, fever, priapism, acute stroke, and in young babies, acute splenic sequestration. And the chronic complications are leg ulcers. This we see a lot, vascular necrosis. We see them a lot also in younger children. They used to be described in older children, but I see them a lot in younger children. Stroke, recurrent priapism. So this is a big problem. We don't know the prevalence because the patients don't really talk about it, because it's a little bit, embarrassing. But when you have a relationship with them, especially the gentlemen, the male health workers, they will actually open up to you and they will tell you that they're actually having recurrent priapism, and it's very, very painful and makes them uncomfortable. Chronic kidney disease, it's starting, we are seeing it, so you need to screen for it. Pulmonary hypertension, I've already talked about it, and chronic lung disease. I'm just going to talk about pain today. I can't talk about all the complications. We'll get another time perhaps to talk about the other complications, but pain is one of the commonest presentations or complications in children and adults with sickle cell disease. It's one of the most common reasons why they will come to you, either an emergency or because of chronic pain. So patients who present with pain must be evaluated rapidly, both for pain and any underlying morbidities, okay? Evaluate for the severity, which can vary from mild to severe. So please take time to evaluate and score the severity of the pain. Do not delay initiation of analgesia. The pain of sickle cell disease is excruciating. It is painful. They cry in pain. So please do not withhold analgesia. I know some people say, these children and adults with sickle cell disease have been addicted to morphine. When they're in pain, please give the analgesia, okay? What forms of pain management do we have? Home-based management is actually the most common type of management. Patients get pain at home and they treat it at home, okay? It includes access to analgesia and the instructions of when to seek medical care. So when you're giving education about these patients, tell them how to manage their pain, but also when to seek medical care. If the painkiller that they've taken is not taking their pain, they should actually be coming to the health centers. For mild pain at home, you tell them you can give paracetamol or NSAIDs, okay? In a few, we may escalate opioids for some unresolving pain at home, but if it gets to needing opioids, they need to be coming to the hospital. You can also advise them to give advanced therapies, relax, take a bath, mild exercise, a hot compress, okay? Avoid any cold compresses, get a heat compress, which can cause relaxation of the vessels and, alleviate the pain. Tell them to seek medical care if there's fever, there's cough, there's signs of stroke or splenic sequestration, or if the first line first aid they're given does not work. What about hospital management? So they've come to you. So majority of the people who come, or the patients who come to hospital, their pain is true. It is not drug-seeking behavior. Of course, there's a percentage that they do, but most of them come with severe pain, okay? Assess where the pain is, where is the location, and what is the severity of the pain. The patient and the parental report is the most important tool for assessment of pain. The mother tells you, my child has been crying in pain, please believe her. She's been the one who has been with the child, okay? Use pain scores for older children, okay? So children who are older than 4 years, they can tell you, it is very severe. For children who are younger, you can use a degree of irritability. Someone has dactylitis, you can tell the child is, pulling away the leg, then you know that the child has severe pain. Assess for any other contributing factors. They might have acute chest syndrome, they might have stroke, they might have infection. These also may develop during hospitalization for pain. So please assess for other underlying factors. These are some of the pain scores. So for the older child, is smiling, hurts a bit, and then hurts the most is crying. Okay, so for those older people, you know, there's no pain, and then maybe worse pain imaginable, or you can use a numeric rating scale depending on how old your patient is. But this really forces you to act differently according to what type of pain severity they have. So what do? We assess the patient's general state, the level of consciousness and hydration. We examine and give areas of tenderness. We evaluate the severity, look for other causes of pain other than VOC, assess the patient's recent use of analgesics, because if someone has given paracetamol, you don't want to be starting paracetamol if the pain has not gone. And then rapidly initiate analgesics within the first 20 minutes of the patient arriving to your health facility. So step one for children, mild pain, give a non-opioid, give an NSAID, you know. Step two, if the child is still in a lot of pain, give a mild opioid, and the difference in the doses. Or step three, if it is severe pain, give a stronger opioid. You can add a non-opioid, for example, you can add an NSAID together with an opioid. For adults, same thing, but just the doses are a bit different. So this is what we use in Malago Hospital. You might have a different protocol. So mild pain, paracetamol or brufen. Moderate pain, you use oral morphine, but it's at a different dose, 0.2, 0.3 every 4 hours. Then severe pain, we increase the dose to 0.4 to 0.5. Okay, and then you can add some paracetamol and brufen. And then you, of course, add a laxative. You can use actually IV morphine at that dose while you're monitoring to avoid toxicity. Okay. Other adjuvant treatments, what else do you do in a child who has pain? Hydration, okay? If the child is not dehydrated and you've overvolemic, just give fluids at maintenance. If they're dehydrated, that's when you multiply it by 1.5, but you should not go more than 1.5 because you don't want to overhydrate them and cause fluid overload, which is going to give you acute chest syndrome. So for all patients who have pain, use incentive spirometry. Incentive spirometry is just blowing something like a spirometer or blowing a balloon for people who have pain, because we have seen that people who have pain quickly develop acute chest syndrome, which is another disease that is associated with high mortality. So wherever you are in your centers managing pain, if a child is awake, let them blow a spirometer, let them blow a balloon, okay? Do not transfuse children with vaso-occlusive crisis. There's no indication unless there are other indications for blood transfusion. So for vaso-occlusive crisis, do not transfuse. If there is no fever, do not give antibiotics. Okay, I know some of the commonest triggers of painful crisis are antibiotics, but if there's no fever, do not give antibiotics. Do a hot compress, avoid cold compresses, and let them walk quickly. Walk around, let them ambulate to actually make the pain management much better. Okay, reassess the pain control at least every 4 hours. Adjust the doses if necessary. Okay, you might adjust the doses of morphine from WHO laddered step 2 to step 3. Okay, you can add additional medication, but please assess response to pain. Okay, try to minimize NSAIDs. We know they cause acute kidney injury. Try to minimize them to 5 to 7 days. Avoid PRN medication. Just say, whenever you have pain, just take paracetamol, or try to dose them and schedule them properly. Okay. So prior analgesia, it helps you to the initial dosing. Whatever they have been using, you can actually, whatever they've been using can help you to know what medication you're actually going to give, okay? One of the complications we have seen, it's not very common, is respiratory depression due to morphine overdose. So whenever you're giving morphine, make sure you need to have the antidote. So if your health center or your hospital is giving morphine, make sure that the pharmacist procures naloxone. It is very good, it acts very fast, but you must have it and you must know how to give it. Morphine overdose actually kills, okay? So this is an important thing I thought you needed all to know, okay? So for people who are practicing in maybe a bit of advanced hospitals, so there's what they call patient-controlled analgesia. Okay, so the patient controls the dosage of morphine depending on how their pain response. And this has found to be very effective, as opposed to us deciding, it's going to need 15 milligrams. Sometimes when there's a lot of pain, increase to 15 milligrams. If the pain is reducing, reduced to 10. So that has been found to be very effective. Intranasal fentanyl has also been effective for acute pain management, especially for those that is not responding to oral morphine. Ketamine has been studied and has been used for pain which is refractory to opioids. But please, you have to be sure that you're able to use like ketamine. And of course, offer psychosocial support. Sometimes this pain is actually, there's a psychosocial problem that is keeping this child to have pain and they're not responding. And of course, offer disease-modifying agents like hydroxyurea to try to prevent the next episode. Chair, I don't know if I should continue or if people want to ask questions now, because I'm going to go into another thing altogether. So sometimes it's not pain. Sometimes the pain is because of an organic disease. For example, liver sequestration, a child is crying of pain, but really it's the liver. So you can, look out for that. Sometimes it is renal pathology and renal stone. So if there's severe pain that has hematuria, think about renal pathology. Pain with leukopenia may indicate an infection. Pain with worsening anemia may actually indicate bone marrow suppression. So if it's not making a lot of sense, you can look for other pathologies that you might need to deal with. So hydroxyurea is a game changer, okay? I want you to become comfortable using it in children and adults with sickle cell disease. It has been here since 1869, when it was used for a treatment of chronic myeloid leukemia, and it was first tested for sickle cell disease in 1984. So it has been here for a very long time. It's probably older than some people on this webinar, okay? So it is a safe drug that has been used for some time. It works principally by inhibition of DNA synthesis, and it causes myelosuppression. So in inhibiting this DNA synthesis in ways that are still unknown, it causes the body to produce hemoglobin F. Hemoglobin F is a type of hemoglobin that is found in the fetus and does not sickle. Okay, so that's the first mechanism. But also because it causes bone marrow suppression, it reduces the amount of white blood cells and platelets that we know cause problems in sickle cell disease. Okay, the thing about bone marrow suppression is it is transient. So don't worry about you getting cancer because your bone marrow is not going to work. It is transient. And once you stop the drug, then the bone marrow production actually continues. We have not seen any resistance or intolerance being described. So whatever doses you're giving are not really going to cause resistance to hydroxyurea. It's not like an antibiotic. So like I said, it has multiple mechanisms of action. It has multiple effects, so if it has multiple benefits to the patient. So it reduces a degree of polymerization, so the other polymers don't form. It decreases damage to the red cell. It decreases hemolysis. It decreases the neutrophil count, so the blood becomes less viscous. It increases hemoglobin F hemolysis and hemoglobin F, just hemoglobin A synthesis. It decreases vasoconstriction. It increases hemoglobin F synthesis. It protects the endothelium, okay? So it protects against the endovascular damage that we have seen in sickle cell disease. One drug, multiple effects to the patient, so therefore multiple benefits to the patient, and this is why we're advocating for hydroxyurea. So it's efficacious. It has been found to be efficacious through several studies that have been here for almost 50 years. It reduces pain episodes by 50%, reduces the need for blood transfusion, decreases the transdoppler velocities that we saw a risk of stroke, decreases the risk of acute chest syndrome, which is a big cause of mortality in children and adults with sickle cell disease, reduces the risk of hospitalization, and it preserves splenic function in infants and improves growth and development in children and adults with sickle cell disease. So it really changes the picture of sickle cell disease. This diagram just shows you how far the trials have been, what trials have been done in sickle cell disease right from 1984 until 2015, when the first studies were done in Africa that showed that it's actually safe and efficacious even in children in Africa. So one of the questions was, does hydroxyurea increase the risk of malaria in children in Africa? Remember, it causes myelosuppression. So does it cause immune dysfunction that can put children at risk of malaria at birth? No, it doesn't. So it has been shown that it is safe. Okay, it does not increase the risk of malaria, it does not increase the risk of infection. So in an African setting, it has the same good effects that we see in children in the West, but also does not give you increased risk for malaria. Okay, so what are the indications? Someone who has very frequent painful crises, more than 5 in a year, stroke or history of stroke, abnormal TCD velocity, low baseline hemoglobin, anyone who has a hemoglobin of less than 6, and that's their baseline, give them hydroxyurea. Any history or an admission for acute HS syndrome, give them hydroxyurea. When is it contraindicated? Pregnancy, or people who are sexually active and are not willing to use contraception, active liver disease, if there's hypersensitivity to hydroxyurea, or if there's significant non-compliance to therapy, don't give them hydroxyurea. However, the guideline is any child who is older than 9 months, any person who is older than 9 months, please offer them hydroxyurea. Do not wait for those complications to happen, because we know it is actually going to happen and it's going to be progressive. Sorry. Okay, so how do you dose? What do you do to start hydroxyurea? What baseline investigations do you need? You need a full blood count with a differential count. Okay, you need a full blood count that is going to give you a neutrophil count, absolute, please, a hemoglobin level, a platelet count, and a reticulocyte count. And then you're going to need the MCV, okay, because you're going to monitor that. So please, those are the baseline things that you need. If you can, get a quantitative HbA electrophoresis, because you want to know, you want to see a response in hemoglobin F increase, okay, if you can. If you can't, it's not, you know, you can do without having the hemoglobin F level. Make sure that your liver, your kidney is working very well. They should be in the normal range. Sometimes it's hard. We shall adjust the dose, and the liver function should not be should be less than 2 times than the normal range. In children with sickle cell disease, sometimes we never really get a normal AST or ALT because of continuous hemolysis, but they shouldn't really be 2 times the upper limit. So do a complete history and physical examination, discuss the rationale, discuss a potential adverse effects, discuss that you need to have regular monitoring, discuss that they need to be adherent. So starting hydroxyurea is not an emergency. Make sure that your patient is going to adhere to the medication. Make sure that they're able to monitor and make sure that they understand that this is not cure, it is just disease modifying. And make sure that you have a documented diagnosis of sickle cell disease. We have seen somewhere in some of our studies that children who have been on hydroxyurea actually don't have sickle cell disease. They actually were carriers. So make sure you have sickle cell disease documented. So initially, your neutrophil count should be above 1,500. Platelet count should be above 10,000. The ALT should be less than 2. It should be less than twice the upper limit. Okay, and the normal creatinine, it's within a normal range for you to start hydroxyurea. Okay, for children, we set at 20 milligrams per kilo per day. For adults, 15 milligrams per kilo per day, because it's a little bit more toxic in adults. You monitor the full blood count every month, the first 3 months, really to make sure the child is adhering to the treatment, and then you can spread it out for every 3 months. We actually spread it out for 6 months for some people because it's not really toxic and they're doing very well. Monitor for toxicity, monitor for clinical and laboratory response, okay? So if you're in a stable dose of 20 milligrams per kilo per day, and maybe the child is not improving, the white blood cell count is not going down, they have a history of stroke, then you can escalate to what we call the maximum tolerated dose. You increase the dose by 5 milligrams per kilo per day every 6 to 8 weeks. Please do not increase every week because it's going to become very toxic. The body needs to get used to this medication. So increase every 2 months by 5 milligrams per kilo per day. So if the child was at 20 milligrams, the next dose should be 25 milligrams, up to about 30 to 35 milligrams per kilo per day. You can monitor the liver and the renal function annually. We haven't seen a lot of toxicities for the liver, but it's just out of caution, okay? MTD is the highest dose the patient can get without toxicity. So for hydroxyurea, the higher, the better. The higher doses actually are better, okay? So, and this has been found to be safe and superior than the fixed dose of 20 milligrams per kilo per day. Of course, it's more expensive, but it's actually better. So for patients who can afford, who can be monitored, aim at the maximum tolerated dose, okay? And you can see from a study that was done in Uganda that patients who on the maximum tolerated dose had a higher hemoglobin, they got a higher fetal hemoglobin, the reticulocytes were lower, and the neutrophils were all lower, which is what we actually there to see in hydroxyurea. So if you can escalate the dose, please do. Okay, so what is MTD? What is the maximum tolerated dose? It's a dose that gives you a neutrophil count, absolute neutrophil count of 2 to 4,000 without any toxicity. So if you can maintain the neutrophil count between 2,000 and 4,000 at whatever dose it is, if it is 20, that's okay. If you can go up to 25 milligrams per kilo per day and the neutrophil count doesn't fall below that, you go up to a dose of about 30 to 35 milligrams per kilo per day. But every time you escalate that dose, please do a CBC to make sure that you're not going below, okay? So what do you do? MCV goes up. But for some children, the MCV does not go up because of several reasons. Maybe they have iron deficiency, but also because we have a lot of alpha thalassemia, the MCV doesn't go up. However, in children who are adherent, they are clinically much better. The pain reduces, the eyes become less yellow, the hemoglobin goes up, they actually have a better quality of life. For children with sickle cell disease and even young adults, please reweigh the patient and check the dose. We have seen children who have been on the same dose, 500 milligrams, and when you calculate the dose per milligram per kilo per day, they're at 5 milligrams, which is not good. So reweigh the patient and adjust the dose. When you stop hydroxyurea, what we call toxicity, if the neutrophil count is less than 1,500, if the hemoglobin is less than 6 and the reticulocyte count is less than 80%, please stop hydroxyurea. That one, it has become toxic. Or if the platelet count goes below 80,000, please stop the hydroxyurea. And then give them about a week, okay? Then you monitor the hydroxyurea. So monitor the CBC every week when you stop the hydroxyurea. And when the counts go up, restart that dose, which is 5 milligrams per kilo per day, lower than when the counts recover. So if your toxicity happened at 20 milligrams per kilo per day, and now you have withheld the hydroxyurea for a week, and the counts have normalized, when you're restarting hydroxyurea, begin at 15 milligrams per kilo per day, okay? Clinical response may take 3 to 6 months. So if you said hydroxyurea, don't expect a miracle. You know that tomorrow they're going to get better, give it time. And let also the patient know it's going to take about 3 to 6 months to see any change. A lack of increase in hemoglobin F or MCV is not an indication to stop therapy, and do not discontinue hydroxyurea because of fever or hospitalization. Unless a child is dying, that's when you can stop hydroxyurea. But for even hospitalization, you can actually continue with hydroxyurea. So what are the challenges we anticipate that you're going to get when you start using hydroxyurea in your clinic or your hospital? The formulations that we have, we only have 250 and 500 milligram capsules. So for adults, that's okay, because sometimes you're at 1 gram, so you take 2 capsules. But for children, 500 milligram capsule, and they only need maybe 250 or 200. How do you actually get an effective dose? So what we do is you calculate the total dose for a week. For example, they need, let's say, 1,500 every week. And so you divide it into 3 days. So you tell the mother, you take a capsule on Monday, a capsule on Wednesday, and a capsule on Friday. That's okay, as long as you can get the total dose for the week. What we are seeing with adults is that as they grow older, they need 2 grams. That means that they need to be taking 4 capsules. Okay, so they're taking the 4 capsules of hydroxyurea every day, are taking folic acid, are taking Fancida. Some of you are giving them multivitamins, you're giving them hibiscus, so they really get tired of themselves and they cannot take all these capsules. So we are hoping that with manufacturers coming now into Uganda, that we can actually get capsules of 100 milligrams or 50 milligrams, and then capsules of 1,000 and 2,000 milligrams, such that someone just takes 1 capsule and doesn't have to take many capsules. Of course, there are no syrups for children. So someone who is 6 months or 9 months, what do you do? The good thing about hydroxyurea is that you can actually dissolve it in milk, you can dissolve it in breast milk, you can dissolve it in juice or in water, and they take it and it's still efficacious. There's a problem with adherence, especially in the young adults and adolescents. They actually don't want to take the hydroxyurea, and you can see them deteriorating. So please counsel them about adherence. And the big elephant in the room, of course, is the availability of drugs. Patients have to buy these drugs out of pocket, and sometimes that affects adherence. Just one thing I want to talk to you before I finish is you're going to hear this a lot, especially in the male patients who are growing up, that they've read that hydroxyurea affects their fertility, okay, that, it is going to affect their sperm count. Some studies were done in rats, and it showed that, hydroxyurea reduced the number of sperms and the mortality of sperms. And then, you know, people are really worried that they don't have children. But sickle cell disease, which is not treated, is associated with fertility challenges and erectile dysfunction. So vaso-occlusion also happens in the testes, okay? So without any treatment, they're still going to get some fertility problems, okay? Some studies revealed reduction in sperm counts, okay? And similar studies have been suggested by other studies in post-pubertal males. But however, the recent studies actually suggest that the reduction in the sperm count is not severe enough to affect fertility. And people who have been on hydroxyurea for years have actually gone on and had children. So please counsel them and give them the right information that without treatment, still they'll have a fertility problem. I'm going to stop here because there's a lot to talk about, and I can see that it is 2 minutes to 9 o'clock. And I can see there are many questions. So the moderator, can we take maybe another 5 minutes of questions?
Thank you very much, Dr. Namazzi. It couldn't have been better. It couldn't have been done by a person more fit to give this talk. Along the way, you kept answering the questions. There are so many questions on the chat.
So many questions in the chat.
But I've been looking through, and I have a feeling that you have actually answered each and every single question, except one, that what will be the next steps if hydroxyurea, if there's a reaction to hydroxyurea. That to me may be the only one which is outstanding, but all the others, there are more than 60 of them. I think you have answered almost all of them.
Okay, so if someone reacts to hydroxyurea, so like I said, the other disease-modifying therapies, chronic blood transfusion is something that we can try here in Uganda. If done well, it really protects the person. But there's L-glutamine. It's not yet approved in Uganda, but we can make a case for it. If someone reacts to hydroxyurea, then you can give them L-glutamine. There's voxolata. There's a trial that is going on now in Uganda. So there are other things that we can actually give. Yeah. Okay. So I cannot take any more questions. I've put my email addresses so that you can email me and we can talk more about sickle cell disease. Sickle cell disease is very wide, so you can't really finish it in an hour. But I appreciate that you all came and I've asked all these questions. And I hope that this has been informative and it's going to change the way you take care of persons with sickle cell disease. Thank you so much.